Good morning, ladies and gentlemen. I would like to welcome you to the second day of the symposium, which is opening the project. Okay, everything is fine, technically. So today we will hear two speeches. I would like to ask Mr. Maciej Piec of the Institute of Oncology. He will deliver a speech called Current Regulations and Practice in Poland on Quality Control of PET-QC tests performed in Polish units. Current methods used to reduce the absorbed radiation dose in PET examinations.
So, the floor is yours. Please open up your mic and video. Good morning, ladies and gentlemen. Can you hear me? Yes, we can hear you very well. Good morning. I'd like to welcome all the guests to the symposium organized by the National Radiation Protection Center. My name is Maciej Piec and I work in the Oncology Center in Bydgoszcz, and I was invited to tell you about the current methods used to reduce the absorbed radiation dose in PET examinations. I will tell you briefly about our unit, about our center, what we are doing, what type of facilities we have. We have 3 PET facilities, 2 PET CT and 1 PET MR. Our center in Bydgoszcz was the first one in Poland having PET CT. We have our cyclotron and we produce radiopharmaceuticals for our own use. And this is an accredited production, and we've been doing it for almost 20 years. So I believe we have accumulated some experience. So I will start with the definition of dose and absorbed dose. In this, more precisely, that's just to highlight what we are going to address. We know that doses in general are harmful to the living tissue, to human tissue, to human body, and we are trying to minimize them in accordance with the rare principle. I could also quote the definition of effective dose. That's more or less the same. So PET tomography, what is this imaging about? The previous project of the center covered SPECT, but here the way the radiation is detected in the case of PET is slightly different. Of course, we knew radiopharmaceuticals, radioactive isotopes, but for PET examinations we need beta plus emitters, and through annihilation we register photons on the other side of the detector. So we have this line of response and the detectors which capture signal from the photons. After annihilation they register counts. And PET technology is being continuously improved. There are different types of detectors, where recently we have semiconductor-based detectors. but greater, if we may say so, popularity of PET technology took place when hybrid tools and hybrid equipment was developed. There are different possibilities, but the most often used is PET-CT, that is a combination of tomography, positron emission tomography with computer tomography. So we get images from both types of imaging. And from tomography, the image from tomography is used for making better morphological assessment of tissues, but they are also used for the reconstruction of PET images. They significantly improve their quality. There are different types of corrections, for example, absorption correction, which allows us to get a more homogeneous image, which more truthfully reflects what we are imaging. And there are also new methods, PET MR. They, with the rise of semiconductors and with being placed on the market and their introduction into PET technology, the equipment could be developed that combines magnetic resonance with PET, because earlier it wasn't possible. So the development on the side of PET detectors allowed this combination of PET MR, which comes and as one piece of equipment. Well, previously we had two different rooms. There were, and the patient was transferred from PET to MR, while right now that this is one piece of equipment and we can use these functionalities at the same time. That means that at the same time photons are detected when PET imaging is taking place, and at the same time we can scan the patient going through different resonance sequences. Well, the subject is to limit, to reduce the dose. Well, it's hard to. It was hard to divide this presentation into the part that deals with the pharmaceutical itself, that is the dose that is necessary for us to perform PET imaging, and another part that would deal with hybrid types of equipment like PET-CT, for example. So, in fact, the subject is rather difficult because dose optimization, well, we optimize the dose following specific standards or guidelines. We use the guidelines of EANM to calculate individual dose of preparation made of different isotopes for an individual patient. But in order to expand the subject slightly, we need to take a step further. We need to know the scans, their sensitivity, their parameters, because what type of equipment we are using further for PET-CT diagnostics informs us to what extent we can reduce the dose itself. So I will try to answer the question what dose we should apply depending on PET technologies and the parameters of acquisition protocols or the parameters of image reconstruction. So this is the first part the dose that is transmitted to patient from the isotope through bolus injection. The second is the dose optimization from computer tomography. So we add these two parts of the dose and we end up with a total dose that is administered to the patient. So two brief slides. Well, in PET examination, we use isotopes, radiopharmaceuticals. These are open radiation sources, which we cannot exclude. So for PET, the dose is also sort of administered our staff, but also patients, when being in some common spaces, they acquire or absorb some of the dose that was of the doses that were administered to them individually. So it also depends on the time spent in the vicinity of isotopes, in the vicinity of the patient. Well, we need to keep the distance. We shouldn't. We should spend, when it comes to our contact with the patient, we should spend with them only the time needed to deliver a particular procedure. There are also additional protection shields. So it's everything quite well worked out, because in our radiology facilities or in our nuclear radiation units or centers, we need to comply with all the requirements for the radiation protection. Also the thickness of the shields and covers, it's all important, because it all together sums up in the dose absorbed by the staff. There are some additional ways to reduce the dose. So, for example, we can, there are covers or for the syringes, special protective cloth, special protective pieces that cover thyroids, and also the reduction of pharmaceuticals. It takes place differently. Some centers purchase radiopharmaceuticals, other produce them, manufacture them in their own laboratories, and the equipment that is used for this production also should comply with all norms and standards of radiation protection, because we need to be aware of the fact that we are working in these facilities on an everyday basis. So these doses, they accumulate in our bodies. They are not indifferent to our health, so we need to take care of our own safety. And here we can see a way in which the dose that should be administered to a patient is calculated. We can use different radiopharmaceuticals, but I quote here the example that is in line with the guidelines of European Association of Nuclear Medicine. These guidelines for PET-CT procedure using FDG as radiopharmaceutical. This is one way to calculate the dose administered to the patient. And looking at the formula, the most important parameter is the weight of the patient, the mass of the body of the patient. But also, as I mentioned it earlier, is what is important is the protocol that we follow to scan the patient. So we need to take into account the time needed to perform the procedure, to perform the detection of radiation from radiopharmaceuticals. There are also other formulas, but if you haven't read these recommendations, EANM recommendations, I do encourage you to do it, because we can find there procedure of the examination, starting from the calculation of the dose through all the protocols. I think this is a very interesting document and very useful. So another issue, because we have certain recommendations relating to the dose. So the question is whether we can reduce this dose or increase it. What does it depend on? Well, we need to be aware of the type of PET-CT equipment that we are using for the detection of radiation. Because, for example, the document that I've just mentioned, it comes from 2016, and from 2016, the technology has changed. The technology used in PET scanners has changed. So we have better detectors, which have higher sensitivity. So from the same activity, they are able to register more counts. And in addition, the fact that they register these counts faster, we have more accurate time of flight. That is, there are minimum differences between the time of flight of photons are also considered, which improves the resolution. So all these parameters may impact the fact that we either get an image of higher quality, of better quality, or we can reduce the dose. And for new equipment, for example, made by Siemens, for example, Vision, which has semiconductor detectors, the crystal is smaller, sensitivity is higher, and the manufacturer declares that around 20-25%, that the sensitivity is higher by 20-25%. So we can try and reduce the dose administered to the patient. And I think it would be sensible to do it gradually. But from manufacturer's declaration, we can reduce it further by additional 20%. So this is another aspect that should be considered when we calculate the dose for an individual patient. Another issue that I'd like to address in my presentation is dose calibrator. This is quite an important piece of equipment because dose calibrators help us identify the dose for a patient, and we find out using this calibrator whether the activity dose is the one that we would like to administer to him or her. So differences on those calibrators, they may also result in certain biases. Well, so 15% bias on dose calibrator may mean that we administer a dose to the patient that is by 15% higher. So this is a very important aspect, and we need to maintain and validate those calibrators regularly, test them. These tests are also considered in legal regulations, in the legal regulations issued by the Minister of Health, how often this should be done. But I have added the measurement on a phantom made with the use of PET scanner. So our PET scanner needs to be calibrated with those calibrated. There is a kind of cross-cut calibration where we take, when we calibrate the dose calibrator for a particular activity and concentration and SUV unit, so that SUV units are measured correctly. I have added this logo of our accreditation. So this accreditation, the fact that we are accredited PET-CT center means that we need to perform tests quite often, minimum every 3 months. There is a special concentration test. This is a good moment to double check whether the bias or deviation on our calibrator has changed or not. After performing the test, after preparing for the test, we need to input the parameters of the phantom, and when we get the reading of 1, then we can find out whether SUV is close to 1. So why am I referring to that? Because in our regulation we have this test. This test is called calibration, not verification test. But in my opinion, I think we should amend it, because when we are performing calibration of our equipment to the dose calibrator, so whenever it shows bigger deviation, we may not observe it, and then we will calibrate. We will make the calibration for the dose calibrator, which may exhibit some bigger deviations. So when we don't like the results, there may be 2 reasons. One is that there is something wrong with our PET equipment, and the other one is that there may be something wrong with the dose calibration. So this kind of verification or validation before calibration seems useful. I myself, in my practice, once encountered a situation when this kind of validation allowed us to detect incorrect operations of dose calibration. And here what else is important? It is important to properly prepare the patient. This slide, I've added this slide to my presentation. I've permitted myself to do that because yesterday our expert, from Mr. John Dixon, he referred to it, and I forgot it when I was preparing this presentation, but this is a fundamental component which impacts the quality of imaging. If the patient is prepared incorrectly, then the quality of the examination is poor. If patients are not informed well enough, if they are not prepared well enough, then we may end up with a diagnosis to increase the dose because of the poor quality of imaging. But the reason may be incorrect or improper preparation of the patient, insufficient water consumption, or incorrect time of waiting, or incorrect conditions of waiting for the examination itself. They should usually be waiting in a room which is quiet and quite dark. They are not expected to move a lot, but they also need to be separated from one another in order not to emit their dose additionally to another patient. So that's worth remembering, and that's worth mentioning, where physical activity before the examination is not recommended. I also remember a patient who came to us for the examination, and he covered 100 kilometers on a bicycle. So he cycled for 100 kilometers, and unfortunately we had to send him away and ask him to come back on a later occasion because we couldn't perform the examination. But of course you need to inform the patient about it so that they know it. So different isotopes of radiopharmaceuticals require special or specific preparation. FDG is the most important, is the most popular. Well, what else? We may reduce the dose by using radiopharmaceuticals that have shorter half-life time. We need to take account of all types of energy emitted by radiopharmaceuticals, because we detect photons that have been annihilated, but we need to consider all types of energy. But I think that half-lifetime is the key parameter that impacts the dose. So if we can administer a radiopharmaceutical that is equally efficient in clinical terms, while the dose administered to the patient can be smaller, it's, of course, we should go for it. So, for example, fluorocholine or carbon marked choline. So for myocardial examination, or myocardial perfusion or prostate cancer, they differ. So this half-life time for the carbon is, I think, 20 minutes. For fluor, it's several hours, and that impacts the dose received by the patient. And a few words about quality control. I've already referred to it, but what is important is for the equipment, for the scanner to perform well. So service inspections, of course, are needed, and often they include tests. So we can be sure that the equipment works well. There are also tests, mechanical tests. So I have also added these service inspections to my presentation. And another step, of course, is the quality assurance and quality control of our systems. I know that the next presentation will focus on quality control and quality assurance in the light of Polish regulations. But all of quality assurance for the detection system, PET detection system, is done by the user. There is a very broad range of basic tests, and we need to control the performance of our scanner. Well, so this is, for example, these are some basic tests. A test with Jack Phantom, where we assess the resolution for sectors. We have different spheres, homogeneous areas. So A test using the Yashchak Phantom is in line with our regulation. That's why I have included it. NEMA body phantom, which in our center is used for accreditation tests. I don't think that it is necessary for basic tests, but it's good to have such a phantom if we want to be accredited, and we also can perform quality assurance in accordance with the NEMA standard. And often manufacturers declare certain technical parameters received from NEMA standard tests, so we can compare their our measurements with reference values given by the manufacturer, and by that we can find out whether our equipment performs well. And another phantom for the assessment of spatial resolution in air. I also edited a document from the International Atomic Energy Agency. This is, we might say, a Bible for testing PET equipment or PET-CT equipment. So I think that all physicists or radiologists who deal with quality assurance and quality control for PET-CT equipment, they are very well familiar with the document. It's really worth reading. So what else? A few words about accreditation measurements. For example, accreditation recommended by European Association of Nuclear Medicine. So we have the examples of results of concrete measurements, and the point is for the detection response of our scanner to stay within the area shown on the graph. So we need to find out whether the response of our scanner is correct, and this is how we get information that our scanner remains within the scope recommended by the accreditation and can be comparable to other scanners that also comply with the requirements of the accreditation. So patients can migrate between different centers, and these and they can be sure that the examinations performed in different centers can be compared. This is a very important aspect. Yesterday, we could see, for example, factors for gamma cameras, well, for PET, qualitative calculations and qualitative research is present, has been present for quite a long time. There are reference values, but I think that the next stage will be the introduction of such standards for SPECT examinations that can also be useful, I hope. I think in dosimetry, I don't have a lot of experience when it comes to dosimetry because we focus on diagnostics, but we have 3 years during which we'll be working together on this project. So I'm sure that we will have time to come back to it. Well, okay, what else? We discussed PET quality assurance and quality control. What's also important is the quality assurance for CT part, that is for computer tomography or magnetic resonance. Of course, quality tests and dosimetry, CTDI dosimetry. So based on these measurements, the equipment calculates the dose for the patient. So this is also important. And rather quickly, a few words a few tricks that you can use to reduce the dose administered to the patient. I haven't divided it between PET and CT because these examinations are quite close to each other, but and when we are using PET-CT technology, we start with a topogram. This is important because based on the topogram, and I'm not sure whether it works for all manufacturers, but I know that for most of them, the topogram image is important for systems that reduce the dose or the exposure for further part of the examination. And from my observation, I can see that the image on the topogram is made incorrectly. So, for example, the technician or the radiologist forgets that, for example, the examination should cover the head, so the topogram is not complete. Or it was supposed to cover only the part of the body up down to the knee, or but it's shorter. So then there are some estimates made. So, for example, well, okay, we should cover this chunk of the body, but we can approximate the results for the rest of the body. But this is very important when it comes for the modulation of the dose. So we should be very careful. This is the topogram may seem little important, but this is not true, because often based on the topogram, we modulate the dose if we use those calculation systems for the CT part of the examination. We need to remember about it because the absence of the topogram for the further part of the examination means that the dose administered to the patient in this part will be much higher, because the equipment will not reduce it, because it doesn't get data concerning the absorption. So it will use medium reference, average reference values, which means the overall dose administered throughout the examination will be higher. And there are topograms based on isotope imaging, or on counts from isotope imaging. Well, that's more true for SPECT equipment, but I also heard that for PET it is possible. You need to be careful, because this is a very nice method to reduce the dose, because we are using the isotope already administered to the patient. But I'd like to draw your attention to the fact that the system of dose control will not work at this moment. So we'll be scanning the patient based on old parameters, which will impact the dose. But if we use low dose parameters for then we can work effectively, and the dose can be reduced. Parameters for computer tomography, that is voltage, intensity collimation, pitch, taking care for the object to remain in the isocenter. That's also important. And briefly, how the tension parameters impact the quality of our image. These are optimization methods. Dose 4D for Siemens. When we use such dose modulation, it can be reduced even by 51%. Where the equipment needs to emit more radiation, it will do it. Where it can reduce the dose automatically, it will do it as well. So these systems are very much recommended. There are different settings for children. and for adults. This is an example of one scan, so you can see how different parameters of the scan what they look like in different parts of the CT scan. So the voltage on the lamp, so we know how the radiation penetrates the patient or the phantom. In Siemens, we get the time. The time is taken into account for the dose, so the pitch or the change of the pitch is not so important for the dose. If we narrow the pitch very much, that the final the voltage on the lamp drops, so the dose is not increased. But for some other producers, some other manufacturers, these parameters are given separately. So by changing the pitch, we can increase the dose. And of course, placing the patient in the ISO center. The patient here is placed incorrectly, it's too high, so the quality of the image is undermined here. And another important element, that is when we scan the patient, we should we have more PET acquisitions to perform, so sinogram or static acquisition, and there can be additional PET scan for the chest, for example, gated. Then it's worth using the possibilities offered by the equipment, so develop broader protocols instead of starting with tomography scan and static examination, and then make another scan and a gated one. So we need to have some knowledge about these protocols, develop these protocols, and try and perform the examinations in such a way to reduce tomography as much as possible, but just use it later for reducing the absorption, for correcting for the absorption, while I know that in some centers all these examinations are performed separately. Other errors are, for example, we can do computer tomography, but there may be mistakes made during PET examination, so too short time on the bed. Some other aspects can be confirmed, right? Time factor cannot be corrected. So when we choose the wrong protocol, so we start PET examination and somebody says, oh well, that's not correct, that's the wrong isotope, we stop and we start anew. You cannot do it, that's unacceptable. We need to use the earlier tomography for all reconstructions to be performed correctly. In 95% of cases, we can eliminate these errors and mistakes, avoiding doing performing additional tomography. I know cases when the equipment was switched off and the patient remained on the table, but SPECT and PET could be completed without doing additional tomography examination. And please remember that the most of the dose comes from tomography rather than from PET scanning. For tomography, diagnostic tomography in certain performed in certain stages, it can be 15 or more. So a patient to whom isotope has been administered, we can repeat the PET because the patient has got the isotope inside, but avoid tomography because that's important. The gating technologies, we heard yesterday the presentation on artificial intelligence. We have also AI algorithms which are added to PET techniques. When it comes to gated CT, we gate it only a small proportion of counts from the patient. But today, using these algorithms, we can practically acquire 100% of statistics. So new technologies, image reconstruction, it all means that we can reduce the dose of pharmaceutical. So treatment planning. In our nuclear medicine centers, we perform procedures which are further used for contouring or identifying critical body organs. And then we fusion them on computer tomography, with computer tomography performed somewhere at the radiology center, and the fused image gets to the center where the patient is treated. So we have a tomography for PET-CT and another tomography which is used for planning treatment and further the treatment planning and radiation to the patient. Of course, we can eliminate this tomography by proper calibration of our equipment. Our PET-CT equipment is fully functional. These are fully functional computer tomography units which can be used for making measurements for computer tomography. And based on our tests, we can directly plan treatment. Well, it calls for more additional equipment, special tables. Sometimes we need a person from radiotherapy unit to properly position the patient, but for the dose, from the dose point of view, it seems a very good solution, because the medical physicists, they take care of this dose to being too small, of being as small as possible. And sometimes you can avoid the doubling of dose administration.
PET and magnetic resonance. Well, I do not have much to say about this device, but it's a brilliant device. Here we can reduce the dose. The resonance is a long-lasting method. So using 5-minute beds, well, these are not the long beds. The standard diagnostic protocol is T1, T2, the gated one, spectroscopy, diffusion, but MR has a much broader imaging scope. So this is for the head, from the head to the pelvis. So a 5-minute bed is okay. During this time we can deliver the main sequences, and if when we use the 5-minute beds in accordance with our formula, which is recommended by the European Association of the Nuclear Medicine, so the standard time for the bed is 2 or 2.5 minutes. Here we are looking at the time of 5 minutes, and we are reducing the dose. And the radiopharmaceutical, there is no dose for the morphology test with providing contrast, the fMRE, spectroscopy, diffusion. It's a very good type of equipment which really provides good dosage, and the diagnostic potential is also quite high. So this should be recommended. However, in Poland it's not recommended. Hopefully it will change in our country. And the final slide, because I was talking for too long, so this is a brief presentation of the system of visualization and reconstruction. We need to remember that the modern reconstruction algorithms, the options provided, also significantly impact the dose administered to the patient. This is the same scan which was performed at the same time and reconstructed in a different way. So this one is typically reconstructed for the lung kernel. The lung window has been used, and we can see that the quality of this image is different than the quality of the image with the basic kernel. So the physician can look at the soft tissue simultaneously with the reconstruction. The studies do not have to be closed, they do not have to be reopened, so it all can be viewed in a single image, so it's easier for the assessment, and the dose required for the assessment can be reduced, which is another advantage. This is the system of visualization. As you can see, we are using two monitors, 4 images on the left monitor and 4 on the right one. So PET-MR exams are visualized in this way, so the physicians can see all the sequences at once. So introducing good assessment systems will have favorable impact on the quality of imaging, and it will allow us to reduce the doses. The individual reconstructions for the specific parts of the body will be sufficient, and the dose will not have to be increased for the patient. The filtering systems, yesterday we heard about reconstructions performed specifically to deliver quantitative assessment. The new systems have an option of filtration, so we can view the results for the SUV value for the reconstructions that have been focused on quantitative assessment, and the images will be viewed in the best possible quality. So when we are looking at the R accreditation, we can change our coefficients of response. We are changing the parameters of reconstruction, so in a way we are forced working with images that meet the quantitative values, and in this case we can deliver the quantitative assessment, and the visualization of the image required by the physician is also possible. And some conclusions. I was telling you about the doses. I was trying to show you when the doses can be reduced. The treatment plan for the patient should be also analyzed in detail. Very often patients are referred to PET-CT or PET-MR, so it doesn't always have to be the case. The physicians can change their decision-making process to reduce the doses. Thank you very much for your attention. I'm sorry I took too much time. Thank you very much for the speech on the methods of reducing the dose. Thank you for the presentation of clinical problems. Well, we have a small delay, therefore I would like to move the discussion about your lecture at 11:30, so please stay with us to make sure that we will be able to ask questions or provide some comments concerning your speech. Thank you very much. And now we will proceed with the next lecture by Agata Sackiewicz of the National Institute of Oncology. And I would like to ask you to tell us about the current regulations and practice in Poland on quality control of PET apparatus in Poland. So, Mrs. Sackiewicz, the floor is yours. We are waiting for the connection. Please switch on your mic and camera. Good morning. I'm very happy that you can hear me and we can also see you. So, ladies and gentlemen, thank you very much for inviting me to take part in the opening of this project. Well, the topic I'm going to discuss discuss is quite difficult. I'm going to present the current regulations on the quality control of PET apparatus used in Poland. And I would like, before I discuss the regulation itself, I would like to tell you about the current status in Poland concerning the use of the equipment to conduct PET-CT exams. Also, I will refer to the PET-MR exams. We have already heard this information in the previous speech. Currently, these exams are not refundable, but hopefully very soon we will be able to use this technology to a broader extent, which will be beneficial for our patients. As regards the legislation on installation and the use of such equipment, in order to start examination using PET-CT scanners, we are required to receive an authorization of the President of the Polish Atomic Agency to use such apparatus that produces ionizing radiation. And we need to remember that this is it's not for the diagnostic purposes, but it's to correct the absorption and to supervise anatomical aspects. So this will be used only for the fusion of images and to locate lesions that will be formed due to the activity of a radiopharmaceutical. It's also related with the fact that we do not receive the authorization for this equipment to use it for the purpose of therapy. If we look at the dose reduction by using the PET-CT scanners without any additional acquisitions for computer tomography, which has been authorized for the purpose of the therapeutic process, well, there is some incompliance which results from the fact that formally the exams planned for the therapy conducted by a specific piece of equipment, we can only treat them as a complement for the exam planned for tomography. And of course, this authorization of the agency should have been awarded. So apart from the authorization by the Polish Atomic Agency, a unit which wants to use such an equipment has to receive a positive opinion of the Voivodeship Sanitary and Epidemiological Station to launch an X-ray diagnostic laboratory and use X-ray apparatus for diagnostic purposes. And please remember this, because in the conclusion, I would like to talk about this issue again. We need to remember that if we want to start the exam, we also need to have some authorization to conduct diagnostic treatment of non-cancerous diseases and palliative treatment of cancer with the use of radiopharmaceutical products. And for the purpose of the diagnostic, this consent is issued by the State Voivodeship Sanitary Inspector, and to receive such a consent, we need an opinion of the regional consultant for nuclear medicine, and to receive this consent, the consultant will actually want to see the detailed procedures based on the standard procedures, and these procedures should describe the overall technological process and the structure of performing such diagnostic tests. As regards the status of this equipment, PET-CT scanners in Poland, we need to remember that now there are huge differences. The oldest equipment date back to the year 27-28, and the latest installations took place in 2021. So we have different technological levels of the apparatus. We need to remember that in the context of the hybrid systems, although they are not refundable, apart from the PET-CT scanners, we also have PET-MRE scanners. So these scanners, which are quite old due to their technological level, they can contain different types of crystals in the detectors. So we can look at analog apparatus with the traditional crystals and digital apparatus which work with semiconductor type of crystals. There are also different fields of view for this equipment. During the latest Nuclear Oncology Academy, we could see the total body apparatus with the long field of view, about 180 centimeters. Now, we do not have such an apparatus in Poland, but we do hope that we will have them soon. So there are different conditions, different ages of the apparatus. Also, the exploitation status is very different. And of course, there are various innovations that are implemented in the available apparatus. We need to remember that there are numerous aspects concerning manufacturers themselves. So, depending on the manufacturers, there are different recommendations how to conduct quality control and calibration procedures. So, there are scanners that have to be covered by daily routine quality tests. There are different performance tests for which sodium 22 isotope is used, so different phantoms are used. They are filled with German. We need to remember that that depending on the manufacturers, we will be using phantoms that will contain the sources for calibration of this equipment. When we are talking about CT part of the equipment used in Poland, there is a standard that is maintained in accordance with the standard for computer tomography. All the devices, all the apparatus will be covered by various tests and controls involving the use of fluorine 18, so the basic isotope we are working with. It is, well, so there is a quite diversity of aspects we have to address when we are conducting tests. We also have to comply with the regulation that lays down the obligation of conducting the tests. It's the regulation of the Minister of Health of 18th February of 2011 on the conditions for safe use of ionizing radiation for all types of medical exposure. Currently, we have an annex that was published on the 3rd of April 2017, and the latest version is the version we should use. So, what does this regulation contain? First of all, there are some principles of performing checks of physical parameters of the equipment. There is information on some some labels. We also have the definition of the medical physicist, medical engineer. There's also a definition of the quality control, which is a set of activities included in the quality management system and consisting of planning, coordination, implementation aimed at maintaining or improving the quality of operating of radiation equipment. It also includes monitoring and evaluation and maintenance at the required level of values of all parameters of radiological equipment, which can be defined, measured, and controlled. Before I proceed with the presentation on some tests, I would like to refer to some pieces of legislation, some paragraphs that also relate to the performance of such tests. We need to remember paragraph 8, which concerns quality management system documentation in radiotherapy. So there must be some descriptions of the tests, the baseline, the performance, and specialized and acceptance tests for the specific pieces of equipment and ancillary equipment. And the next paragraph is paragraph 9, which lays down the extent and frequency of conducting the tests, regardless of the frequency of making the performance tests. We need to remember that after each repair of the device that can in any way impact the diagnostic assessment of the specific study or image, and those administered to the patient. So a performance test should be repeated, or even some specialized test, specific tests should be performed to justify the specific change. When we are talking about the equipment, radiation equipment, actually we need to have a consent to use them, and the test can be done, the exams can be performed in accordance with this consent. And if the consent has not been granted, the provisions of the applications for such consent should be met. We must not use radiation equipment that have not been covered by performance specialist or baseline test, or if such test results exceed a threshold value, actually all these aspects have been laid down in Annex 6 to the regulation. There's also item 22. In many cases, we are using this paragraph for PET-CT scanners, so we are talking here about the control of physical parameters of radiation devices and ancillary devices other than the ones laid down in Annex 6 to the regulations. So they should be done to the extent and frequency resulting from the Polish norms and other standards. The regulation also lays down the provision that the test should be appropriately documented, and the system of performance of the test should also be documented. So I'm sure that in the hospitals you will be referring to the documentation concerning quality assurance. You will be referring to the schedules of such tests. So these are all the documents that will be inspected during audits. The regulation also lays down on the duration of keeping such documents. So they should be maintained for the period, just like the X-ray images are maintained. And also we need to notify the sanitary voivodeship sanitary inspector information on negative results of the tests, and we should also provide information on the corrective measures implemented. So this is a mandatory notification. Well, there is also one item which is not directly for the PET-CT scanners. So in this case, as you will be able to see later in my presentation, for the PET-CT scanners, such specialist tests are not really covered by the regulations. There are no guidelines. Also, there are some provisions concerning the measurement equipment used for the measurements of physical parameters. So, of course, these devices have to be calibrated, they have to be checked, it has to be remembered when performing the tests. In Chapter 3, which concerns nuclear medicine, there is information that is quite worth knowing. However, what is missing, there are no references concerning the tests for the apparatus itself, and Chapter 9, transitional and final provisions. This regulation is amended, so there is paragraph 59A, which lays down that as of the 1st of January 2012 until 31st December 2012, the tests laid down in this paragraph, they can be performed by entities which are not accredited. So the state sanitary inspection laboratories and entities authorized by the state sanitary inspector, and until the 31st of December 2015, medical physicists or a medical engineer, they are the professionals who do not have specialization. However, they need to have at least 5-year work experience, work at the healthcare facility in terms of medical applications of ionizing radiations. So this is a bit complicated, but because when we are looking at the medical physicists or medical engineers, actually their number is very limited, and now these specializations can be partial. So, for example, they can be specialized in X-ray diagnostics or nuclear medicine field, and for now, due to the fact that we had pandemic, this is something, this is now the time when we will start having more such resources. A part of Annex 6, I would also like to refer to Annex 1, which concerns requirements on description and review of images, digital images. So there are both detailed and general requirements, so there are no direct references to displays and viewing of the images provided by the nuclear medicine solutions. So this authorization we are receiving, it's the authorization to use the tomography in the field of correction of absorption and medical imaging, anatomic imaging. So we cannot treat the tomograph apparatus as the device that provides an image, which is a typical image used for the purpose of diagnostic assessment. It can only complement the image of nuclear medicine once the tracer has been administered for the purpose of PET-CT exam. Do we refer practically to the detailed to the detailed requirements? Probably yes. Recently, when our centers were purchasing the apparatus, we would like to have specific displays, monitors that would allow us to download tomographic image from the radiology ward, and we would like to be able to compare such images made by CT in other locations. So now I would like to refer to Annex 6. So it contains a chapter on PET-CT scanners. I would like to mention that in Poland, the PET scanner itself has not been installed. The PET-CT, the scanners installed in the years 2007-2008 were the hybrid solutions. So now I would like to talk about the baseline tests of the apparatus used in the nuclear medicine. So the tests recommended by the manufacturers should be performed. So we are again back to the information I have covered before. So there are several manufacturers who have installed their equipment in Poland, and we have to address this aspect. So there will be different tests performed. Luckily, the regulation, there is such a provision which is very practical, and we can refer to this provision. So some methods of test performance, the frequency and criteria should be compatible with the specification of the manufacturer. What else is included? PET detector stability. So we need to perform the test using the source recommended by the manufacturer in accordance with the recommended methodology. A criterion is covered in the guidelines of the manufacturer. Frequency is a very important information, so it has to be done on daily basis. We also need to remember that the tests I'm going to talk about in the further parts of my presentation, the scope, the extent is as follows. Methodology excludes some parts. Once we conduct a specific procedure, the system allows us to start another test. So this is also very specific for the specific apparatus and respective manufacturers, or maybe, first of all, it depends on the manufacturer. Another test is the test of normalization. So it should be performed using a phantom or source recommended by the manufacturer, depending on the manufacturer. These can be tests performed using different sources. Usually here we are using a visual assessment to check whether the sinograms are correct. The criterion is not defined. Frequency, it's according to the recommendation of the manufacturers. And this is done under a daily quality control measures, and the system will enforce to conduct such controls, such tests. Homogeneity of the reconstructed image. This is the third test we should perform. So here we should use a homogeneous source. For some equipment, this can be a cylindrical source which is used for daily quality control, or it can be a cylinder filled with the solution of fluorine 18. Reconstruction should be done with the use of all the corrections and typical parameters used in the clinical environment. So in the visual assessment, we are looking at the reconstructed images. So in different cross sections, no artifacts should be visible. And the frequency is every 3 months. When we are looking at the quantitative assessment, the deviation, we are looking at the deviation of the computed heterogeneity, deviation from the reference value. So here the maximum, the criterion is 5% and frequency is every 3 months. And the fourth type of test is the calibration of the activity concentration. So it should be performed using a phantom recommended by the manufacturer. Frequency of performance of this test should be scheduled every 3 months. The fifth test is the image quality. This test should be performed using the cylindrical phantom containing elements, specific elements to assess spatial resolution. We should also we should check whether it's in line with the homogeneity of the reference image. We also have to check whether there is appropriate differentiations of the cold spheres in the image, whether it's in line with the differentiations in the reference picture, and this test can be performed every 6 months. Another test, which is done every 6 months, it's the test of the tomographic resolution, spatial resolution in air, and it should be done using 3-point align sources located in the air in specific locations, and the deviation of the tomographic value from the reference value can be 5% maximum. The seventh test, it's matching tomographic scans of using the scans, PET and CT scans. So this test should be performed using dedicated phantom with distributed spatial point or line sources for using reconstruction methods and post-reconstruction parameters. So here we are looking at, again, the guidelines of the manufacturers, which should be clear how to perform such tests for the fusion images, for nuclear medicine and tomographic test. So we should assess three planes, and I have already mentioned that it should be done every 6 months. And the CT module test for the PET-CT scanners, where the CT module is used for the purpose of diagnosis. So all the tests envisaged for the PC scanners should be performed, and again we should get back to the issue of the authorization to use the PET-CT scanner. CT is not treated as the module used for the purpose of diagnosis. It should also be used for the purpose of the correction of absorption and anatomic imaging. However, if we are authorized by the region voivodeship sanitary epidemiological station, and if we performed all types of the tests for CT scans, we could use this apparatus as a CT scanner without the use this PET section part. Referring to the previous lecture, I think that this test provides us with the comfort in some clinical cases performing the fusion exam, that is the PET and CT exam at the same time. in terms of using the parameters for CT scans done for the diagnostic purposes. It allows us to reduce and to exclude another CT scan. However, we need to remember that all these tests have to be performed in accordance with the guidelines for CT tests, and even if we have no reference to specialist tests for the tomography, for the scanner, for the PET scanner, then the specialist tests should be done for the CT portion. They should be used. To sum up, specialist tests for the PET, there are none. We have already heard that when we are using the apparatus, we are using the option of making CT scans as a fully diagnostic exam. We are required to conduct specialist tests applied for tomography. If we are using PET to plan the treatment, we need to remember that it's only an addition to overlap the fusion of the images for the equipment that has been licensed by the Polish Atomic Energy Agency, and the scanner, the PET scanner itself, is not authorized for these purposes, so formally we cannot use it to plan the treatment. And the apparatus to plan a treatment has a completely different scope of tests that should be performed for this apparatus, and we need to remember this, we need to address this. Some of these tests wouldn't be possible to perform at PET-CT apparatus due to the construction of such equipment, due to the fact that PET-CT apparatus is used in 80% for the purpose of diagnostics, and it is used in diagnostic beds, and the palette for planning treatment is an addition, something that is added. So it would be hard to obtain some information on the deviation for this palette of tests envisaged for the equipment used for treatment planning. I think that we should take a similar approach to CT scanners without a PET module. When we are talking about the use of such apparatus for the purpose of diagnostics, I think there are no contraindications when we are looking at the scope of the baseline specialist or performance tests, addressing the use of such apparatus for the purpose of diagnostics. Baseline and specialist tests include descriptions of the procedures that should be met during the tests. And that's the end of my presentation. I think that I have told you, I have provided you with good information on the tests provided in this respect.
Thank you very much. Thank you very much for your very exhaustive presentation concerning tests for PET. I would just like you to comment, to allow for just one comment. Well, I'd like to remind you the Act on Atomic Law. A medical physicist can be also a physicist, especially trained in nuclear medicine, or a physicist who has completed a specialist training in nuclear medicine. Yes, yes. Well, so these courses, these training courses should start soon. Well, as we've said, well, the pandemic has stopped many of us of our activities, but we are currently working on a new regulation covering also tests for equipment used in nuclear medicine and also tests for them. So I encourage you to take part in the consultation, in public consultations. So be agile and cooperate. Yeah, I assure you that we will be following that closely and we will be active. Thank you very much. Do we have any questions from the audience? Well, questions concerning this very presentation. So you could either raise your hand or write a question, text, or write a question on our chat. Don't see any, but now we are. This will be the last part of our symposium. I'd like to ask all of you who'd like to make your activate their cameras and microphones, of course. We'll be discussing in Polish and in English. So please also take care of the channels that you are using.
Good morning, still good morning to our colleagues from different countries, our experts from International Atomic Energy Agency. I am looking on the list and I see here Tomo Furusawa. May I ask you to connect with us? And Professor Bogdan Małkowski.
Professor Bogdan Małkowski is with us as well. Could I ask you, Professor, to join us? And all other participants. I'd like to invite Professor Ratajczyk. And possibly, I'm not sure if we are having Mrs. Agnieszka Mąkowska with us, the spokesperson for the agency. Mr. Piec is missing for the roundtable discussion. I hope he will.
We are going to the end of the opening meeting of project Technical Cooperation Project POL9027. This is the end of the first meeting, but this is the beginning of the project at all. This project will be continued during next 3 years, and it's a lot of time. I hope. Good morning, Professor Bogdan Małkowski.
Good morning.
I'm sure that our guests from agency, as experts, for sure you remember Bogdan Małkowski from the previous project, and I hope you stay with us during this project too. Okay, let's start to general discussion of 2 days of this project. May I ask you for some comments to the project at all? If you have some ideas, tips, or something like that, please take part in the discussion. I tried to discuss these two today's presentations on the presentation. This presentation, in my opinion, there were the presentation which are directly pointed to the quality control. I mean, how to reduce dose. It's obvious that the dose and the quality of the image or diagnostics, they are very related questions at all, altogether. And it was, now we have in Poland the discussion on the quality control in Poland is based on two parts. One is the quality control made in nuclear medicine departments by staff, and the second part of quality control is made by accredited laboratories or medical physicists with the specialization. And yes, that's right. We have at this moment no tests on the national level recognized by national accredited laboratories, but we are working on it. So this is not like in many countries in Europe that there is the quality control is depends on the staff in nuclear medicine or radiology departments. We use two parts. One is for the staff. The tests are called basic, and there is some tests, as Agata Sackiewicz mentioned, that which are made in departments. And oh, hello, Maciej Piec. And unfortunately, but this unfortunately is because there is no clear, when we have to put tests into the national regulations, we have to be sure that all tests may be done by all nuclear medicine departments on all devices. This is the question, because when we, for example, there are some tests based on Yaszczak phantoms. This is the commercial phantom. So we could not put this into the regulations because, yes, we know that the Yaszczak phantoms are used in nuclear medicine, but it couldn't be in the regulation because when we put it there, we put some trade mark into the regulation. This it couldn't happen. So that's the question. We have to look for the other solutions. For example, NEMA phantom, it's okay because this is NEMA phantom is not this is not commercial solution, and so on and so on. So that's in nuclear medicine, especially for PETs, we have a problem with the tests which have to be included into the regulations. So that's the question. So, well, sorry for such a little bit long explanation for tests. Any more comments for today's presentations?
Can I say something?
Oh, yes, please.
Good morning to all participants. And at the first, I would like to emphasize, pinpoint that this part of our work, it means radiation protection is very important, and all workers should have in mind that should reduce dose. This is trivial, but not all is used by our colleagues. In Poland, we have a very specific situation when the payment for the study doesn't include separate part connected with radiation protection. It means that when we introduce any procedure, we must think about who and how we will pay for it. It is important because all work is connected with payment. That's why, apart from it is important, it is very useful for patient and for us. We haven't any tools to increase flow of money for these very specific procedures. And this is important thing about which we should think introducing any law, because according to me, it is very easy to introduce. We have to, we should do something, but when we try to execute it appears that we haven't no one who will do it. We haven't place, we haven't any equipment. And it is important to connect these things from one side, the technical possibility, from the second side, financial possibility, and for the third part, personal possibilities to do these proposals. And I think this study, this grant, should realize our society, our clerks from health ministry, that this is important and we should find a solution. And what is important for me, because you know, our Polish colleagues know that I am a fan of PET, that this project is strictly connected with PET. And I think that when we tidy our room on this area, we will be better and will be something which should be done much earlier and would be done now. Thank you very much.
Thank you very much for clear description of the situation of nuclear medicine in Poland. That's right. So we discussed 2 days on staffing, on money, in relation to high tech and artificial intelligence, which is going into the nuclear medicine. So that's right. Maybe some more comments from. Yes, John, please.
Yeah, I've enjoyed it. I'd like to also thank the interpreters who've done a great job. So please, I'd like to thank them. I had a couple of comments on the first presentation this morning about dose reduction, and there was mention of new technology and the semiconductor, the silicon photomultiplier tubes, and longer field of view. So now we can get PET scanners that can scan 25 centimeters at one time. And I just wanted to flag that there is an E&M document that was published, I think, in the last month, which allows people who have those instruments to reduce the injected activity they might use on them. And of course, this covers things like PET-MR as well, which again has 25 centimeters of PET. So I just wanted to highlight that. And the other thing I think that the first speaker mentioned this morning as well was about EARL accreditation, and that it's very welcome in PET, and it would be nice to have it in SPECT. I just put it out there that there is an initiative going on within EARL at the moment, which will put an accreditation schema in place for lutetium-177 SPECT. So we can use this when, if we can find money to do dosimetry or any post-therapy imaging for lutetium-177 therapies. So I just wanted to highlight those 2 points.
Maciej Piec, for the comment.
Can you hear me, Carlo, from there?
Yes.
Yeah.
Yes.
I can add a news. I'm in close contact with the IFOMP, the European Federation of Medical Physics, and there is a work group that developed a protocol for PET quality control, routine quality control. So in PET, maybe you realize that the NEMA tests are not suitable for routine quality control. They are too complex, too cumbersome. And so the missing part is what shall we do on a frequent basis, on a routine basis. So IFOMP developed this document, which is almost published. So stay alert. Maybe I can inform you when it will be released, but it's a matter of few days because they planned to publish before the end of the year. Then they had some internal bureaucracy, some internal approval, and I know that they are just in the graphical correction phase. So just the aesthetics, the content was fixed. So this will fill a big gap that we have in nuclear medicine quality control. And it is conceived to be feasible by all the centers, not requiring special phantoms. So it can be useful for the community.
Yes, we are looking into the new publication on these topics. And yes, but I see that we are not ready at this moment to put the general regulations on quality control on PETs, of course, into the national regulations. That's the question. As I mentioned, that it's very easy to make quality control if someone want it, need it. To put into the routine in nuclear medicine department. That's easy. So even in our regulation, it's stated that if there is no information on test in regulation, you have to use at least producer documentation. So that's the easiest way to solve this problem. But we are facing general tests which we may put into the regulations, national regulations, which can be useful for nuclear medicine parties. And quality control for patients. So that's the question. So we have to be sure that what we put into the regulations will be useful for all nuclear medicine departments and devices. This is the question, because it is very easy to put some regulation, and there are some tests like this, which are very interesting for the devices from one producer, and the other producers cannot fulfill it because of some technical reasons, for example. So that's the question. But we are looking on all news in this matter, in this topic. Yep. Maybe more questions or comments for these 2 days? I am looking for hands now. If you remember, you have to go down right on the screen, and you have the face, happy face. This is status. And when you press there, you will have a rising hand there. So you may use this to make some comments. And of course, first of all, you have to connect to microphone. That is the first thing. Maybe Tomo Furosawa, are you with us? Have you any general comment as agency representative?
Hi, good morning. Can you hear me?
Yes, perfect.
Hi. At this moment, I do not have any comments, but if there are some questions related to the project in general, I'm happy to answer.
Okay. Oh, hello. We see you now.
Yes.
Okay.
Well,
Yeah.
I can add something very general,
Carlo,
if possible. If
yes.
nobody else is speaking it, I think that I saw this morning that you spent a lot of the quality control of the equipment, and I also see that in general, we have a directive, European directive, the 2013/59, that push a lot for physics in nuclear medicine. But my experience and my this is a personal idea, is that, of course, as medical physicists, we should cover the quality control and supervise the quality control. Here in Italy, we are organized in this way. Routine quality control are performed by technologists, and the medical physicists just take the results and supervise this. And the medical physicist is personally involved in the most advanced test and acceptance test. Of course, the expert in radiation protection should take care of protection of worker, but I think that we should address a lot of our time and energies to the therapy of nuclear medicine. Maybe you don't know, but I heard that companies are releasing a sequence of pharmaceutical to treat many cancers, not only the historical thyroid cancer or neuroendocrine. We are in few months, we will have the prostate cancer treated with PSMA labeled with lutetium. There are studies for breast cancer treated in nuclear medicine. There are a lot of new agents, and the main responsibility that the physicist has, at least in Italy, is to evaluate the dose and to optimize the therapy. So in the future, I think that we should be, of course, able to supervise quality control. We should have to follow the radiation protection, but the important and new role will be as an external beam to plan the treatment for patients on a routine basis. This is something that we have to push, because we can really increase the quality of the nuclear medicine therapy and to improve the patient outcome, the outcome of patient, as we saw yesterday. So this, if you have a long-term plan, this should be very important because it's a direct impact of the medical physicist on patient care, not only on equipment care, not only in staff protection, but this is the new and emerging role that it is for me is a must, because we pay attention to reduce the dose to diagnostic patient, which is of course welcome, but much more important is to deliver the good dose to therapy patient, not to kill them with microspheres in liver, for instance, and to cure them, and not just to make some kind of treatment that gives some response in some patient. We should care about giving the best treatment to each individual patient, because we are treating life-threatening disease. We are not only treating hyperthyroidism, we are treating cancers and aggressive cancers. And so I think the role of the physicist should be mainly devoted to this part, which is the most important for patients, for our patient. This is the general comment I have. And it is my commitment for since 2000. I'm working so hardly in this because I think that nuclear medicine patients, they are not in lower class respect to external beam. They should be treated in the same with the same quality, possibly. Of course, we don't have the same accuracy because we don't have the same accuracy in quantification. But I don't see why our patients should be treated as low-class patient. They are not low-class patient. They are same level, and ethically they should be treated with the same quality of treatment.
Thank you very much for your comment. That's right. We recognize here in Poland as emerging role of nuclear medicine in therapies and in diagnostics. Yes, you're right that main goal is to cure, main goal is to diagnose patients, but this is the chain, and this is the problem, because without one of the piece of this chain, it's very hard to proceed. I mean, you mentioned it's the money, staff, the devices, recognizing of the nuclear medicine, and so on and so on. So all of these parts of this chain must be pressed, and I hope that the project like this one and people who are involved in such projects we try to, for me, I'm sure our organization, I mean National Center for Radiation Protection in Healthcare, we will promote nuclear medicine for sure. So this project is the point of our interest at this moment. So you're right. Nuclear medicine could not mean that this is the second class treatment methods and so on, diagnostics. So it's going on and it's emerging all time. So maybe Professor Bogdan Małkowski, some comments for this, if you would like. So you are a specialist in nuclear medicine, you are a medical doctor, so I am sure that
I don't feel like the second-class specialist, but the truth is that the number of nuclear medicine, Polish Nuclear Medicine Society is very low comparable to other societies, and it caused the situation when the power and voice of these others societies is much stronger than ours. And in this competitive market, of public of health, it have a very special meaning. And I think that we must work, we must do everything which is possible to show our speciality on the background of these others, and to pinpoint the advantages of using radioisotopes. And I think we should try to work on the background, on the very beginning of the process of acceptance, particular procedures, because when they are set on the end of treatment process of the patient, for example, after the third or fourth relapse of the disease, the results are much worse than when we trying to treat the same patient in the early stage of the disease. And we must remember that this work is done by Polish Nuclear Medicine Society, but after 6 years of my being the president of this society, I have some doubts because the bureaucratic procedures are very slow, and that's why any help, any adding something to this work is still necessary for being visible. Thank you.
Thank you very much. I support your statement, really. I hope that we will chance to press Ministry of Health, especially and National Health Fund, to change the mind. I am sure that it will be not easy and it will be long-lasting, but we have to start with this. Okay, some more comments or questions, or we have to go slowly to the end of this meeting. If not comments in English, I change my language now to Polish.
Na Polski. Ladies and gentlemen, do you have any comments or suggestions concerning the presentations? I address mainly my Polish colleagues. You can, of course, speak Polish, because and what about the representatives of the Polish Atomic Energy Agency or the main sanitary inspection? Mrs. Monkosa, are you with us? Or perhaps Maciej Ratajczyk? Yes. Good morning. Oh, good afternoon.
Hello, everyone. So far, I haven't got any comments to the given lectures, but I really appreciate the information which you were provided. And from my perspective, the given lectures are regards topics which are vital in terms of radiation protection, nuclear medicine, and was pleasure to hear you. Thank you very much.
Thank you very much for short, warm words. To be clear, Maciej Ratajczyk is from Chief Sanitary Inspectorate. He is the Deputy Director of Department of Environmental Hygiene. And some more comments? If not, I would like to thank you, all our guests, all presenters. I hope that all audience too, of course, there's a lot of people joining us. I saw that on Vimeo platform, there were in peak some more than 20 persons available there. So that's very charismatic talks, and we got almost 30 persons on Vimeo, and sometimes it's just about 20 persons here on Click Meeting. That's a lot of people interested in nuclear medicine. So thank you very much, all of you. I hope that we have chance to meet us first time here during this project, POL9027. And I hope that we can and we will collaborate during the next 3 years. Thank you, presenters, once again. I hope that we stay in touch, and if someone would like and someone have the questions, we may contact John, we can contact Tomo, Margarita, and sorry for, and just a moment, Carlo, sorry. Well, once again, thank you very much, and see you next time on the in live, probably not on the screen, but probably we will do everything to invite you to Poland, to see Poland. I'm talking to our guests from abroad, and hope that we will chance to meet us in Poland, especially in Łódź. This is our city. Thank you very much.
Thank you.
Thank you.
Once more, one more question. All presentations and from this meeting will be available on YouTube channel very soon. We try to make very soon too. We try to make some translation into Polish for Polish people. So subtitles with the presentation will be with subtitles. And as usual, we publish it in YouTube, all of them. Thank you very much once again. And that's for sure.
Thank you.
Bye.
Bye, everybody.
Bye bye. Bye bye.
Thank you very much for your attention.
Thank you. Bye.